Hello everyone, and welcome to the 30th episode of CBCLIPS. In this episode, I present you with a baby girl who presents with a neonatal intestinal obstruction, high suspicion of cystic fibrosis because both parents are carriers. And the question is what to do next. So let's start looking at the imaging first. On this supine view, we see a distal bowel obstruction, lots of distended loops, but we do not see the soap bubble appearance that is quite typical of meconium ileus. We also see a thin rim of calcification, and we have to ask ourselves, does that mean that there is some type of meconium obstruction, possibly complicated? When we look at the decubitus views, we see multiple air fluid levels, and when we look at the contrast enema, we see a severe microcolon. In this case, as I mentioned in the scenario, the radiologist did not reflux back into the distended bowel. So the question is, should we ask the radiologist to repeat the enema and attempt to reflux into the distended bowel as a potential treatment for meconium ileus? Now, look at the images of this other patient who has classic meconium ileus. What do you see here? You see absence of air fluid levels, and you see a colon that is small, but not quite a severe microcolon. So in this case, we did not ask the radiologist because looking at the imaging, we applied two clinical principles. The first was that air fluid levels are extremely rare with meconium ileus, and the second is not all calcifications seen mean that there's meconium peritonitis. You can get calcified or insippisated meconium within the bowel lumen. The other important clinical principle is that not all obstructions in the setting of cystic fibrosis have to do with meconium ileus or meconium cyst or meconium peritonitis. You can also get atresia in the setting of cystic fibrosis. And in fact, we took this patient to the operating room, found a type 3A ileal atresia with a volvulus distal to the atresia, resected, did a primary anastomosis. Thank you, and until the next CBCLIPS.